Kia ora koutou. No mai haramai. Welcome to our In Conversation. Today I'm joined with Jonathan Armstrong, who's the Clinical Allied Health Director for Allied Health for Counties Manukau and Professional Lead for Occupational Therapy. And Jonathan's been in that post for 2 years now. And prior to that, he was Director of Rehab at AB Rehab, which I think is based in Auckland.
Yep.
So welcome, Jonathan, and thank you for taking the time to have a conversation with me about how COVID-19 and the lockdown and at level 4 and moving to level 3 has affected the occupational therapists working in your DHB. So maybe I can start there by saying, how is the DHB managed or managing during the lockdown? What are the issues from your perspective?
I think in general, the DHB is managing really well, and it's really well placed in terms of managing COVID-19. And I think we have the people who stayed at home for the last 4 weeks to thank for a lot of that. There's been significant amounts of planning in terms of how the DHB manages at the different alert levels. And a lot of that planning has had to happen with lots of regional collaboration and collaboration with the public health services, as well as just focusing on our own DHB. There's certainly been a lot of challenges in terms of that planning, the speed with which we kind of had to move in terms of aligning our services to the changing context was pretty interesting. Some of the challenges were also around establishing, what exactly essential healthcare was. That term essential is pretty broad, but when we really nutted it down to the nitty gritty, that essential kind of came down to maintaining people safely in their own homes, preventing people from being admitted to hospital if we could support them and their health needs in their own homes, and getting people discharged from hospital as quick as we could. So everything kind of revolved around those sort of 3 main aims. And I think what was good was that in terms of aligning ourselves with other Northern DHBs, we all seemed to come to the same conclusion at the same time and work around sort of the same, putting in systems and processes that all met those kind of 3 main aims in terms of keeping people safe at home, preventing admission, and getting people out of the hospital as quick as we could.
So in that multi sort of professional arrangement, which you're referring to there from your DHB's perspective, and then collectively across the Northern DHBs, the voice of occupational therapy as a profession, how is that, what's your view on that, how the DHB, your DHB and the other DHBs have managed that? Do you feel that the profession has been heard?
I think, I do. I think particularly in our DHB, we have a good allied health voice at that strategic leadership kind of level. And I think the importance of occupational therapy and allied health as a whole was really seen as kind of instrumental in terms of the idea of keeping people safe at home and discharging people from hospital in particular. So I definitely feel like the contribution of occupational therapy has been recognised in terms of those kind of main goals of the DHB.
Okay. And obviously Oaties work in a number of places within a DHB setting. Have some of those places had to close down? Has there been reallocation of resources? I'm thinking outpatient clinics or a rehab sort of clinics, things like that. What's been the picture there?
So it's not so much that they've had to close down completely. What has tended to happen is that they're just having to deliver their services in a more creative way than they perhaps have had to in the past. So taking sort of outpatient clinics as an example, outpatient occupational therapists, say things like hand therapy, they're still delivering their clinics, but they're doing it via telehealth.
Right.
Or they're still offering essential kind of clinics to people who've had acute injuries and are still requiring their input, but they're having to do it they've divided their team in half and they're having to do a lot of physical distancing, and they've reorganized their clinic space so that there's less foot traffic through the clinic space and all those sorts of things. So they're still providing services. They're just being much more creative about how they're doing it.
Okay. And now we're moving, it's signalled, obviously the Prime Minister's signalling we're moving to level 3 next week. What does that mean for the OT service at Counties Manukau?
We've had to do a lot of work as we went into level 4. We had to do a lot of work in terms of reprioritising the workload and sort of looking at, for those people who are deemed, to require essential services, that magic word essential again. For those people who did need those essential services, how those were going to be delivered in a more contactless kind of way. Moving from level 4 to level 3, we don't see that a lot of that is actually going to change. We still need to be doing all the physical distancing. We still need to be screening people. We still need to be offering what we can remotely. We still need to be respecting people's bubbles and not, moving from one bubble to the next. What I do see as perhaps changing is that our own sort of work size bubble is probably going to be extended. So people who work across community bases, whereas at the moment we've kind of got them restricted to one base. Mm-hmm. They might be able to start working more flexibly across the bases as they used to. People who, things like elective surgery, we're sort of waiting to hear in terms of what elective surgery might restart. So that would sort of increase our referrals around sort of the surgical procedures that we're not currently getting. So there will be some change, but in terms of the massive change that we had to make in the ways that we were working sort of 3 or 4 weeks ago, there's not going to be a massive shift in what we're doing now. Okay.
And moving on then, just what are the challenges for OTs in the DHB? Just generally.
I think, as I've kind of already alluded to, one of the big challenges was limiting our movements. So, we've got a lot of OTs that work on things like in-reach services, outreach services, physicians that work to kind of help with the transition of patients. We've got physicians that work across acute allied health and rehab, or rehab and community. So we had to really start to sort of isolate people in sort of one workspace. So they've really had to limit their movement. That in itself has been quite a challenge. I think the other challenge has been that they have had to reduce services, and that's been tough from kind of an ethical point of view. And as occupational therapists, we're used to working on focusing on community integration, for example, and when nobody's allowed out into the community at level 4 restrictions, there's not a lot of community integration we can do. But but things like, you know, the limitations on things like housing modifications and vehicle modifications and return to work, and the kind of things that we're used to providing, we've had to stop providing for a while, and that's kind of been a challenge for OTs. I think also the amount that we're relying on patients to self-manage, or for family and whānau to assist patients to self-manage. We've had to come up with a lot of resources around how people can manage their health conditions themselves. And in terms of the delivery of our health services, like I've already mentioned, you know, telehealth is something that all of a sudden everybody is trying to get on board with and get on top with. And it's been interesting to see how some people have just picked it up and run with it and embraced it and are giving it a go. But yeah, there's been a lot of upskilling in particularly in telehealth, and sharing resources online and sharing screens, providing demonstrations through video demos. And I think we still have a long way to go in terms of getting comfortable with that sort of media.
I guess the nuts and bolts of occupational therapy, wherever it takes place, is that personal contact, and picking up those signals, those non-verbal signals that you see when you're meeting with people, that it's not as easy to do with telehealth.
Yeah. So there is, I mean, there's the initial challenge of occupational therapists getting used to the technology and what they can do with it, and the best ways to use the technology. But then you're right, there's also the, you know, one of the big challenges and one of the things that people are concerned about is that building that therapeutic relationship, and how do we build that, you know, using this kind of technology. How do we build a relationship with our patients so that we get the best outcomes?
So are staff tending to come into the DHB, to their normal work environment, or are they working?
We have a combination, actually. We have a combination. People have been enabled to work from home if they need to. So they have all the tech that they need to be able to do it. But it just doesn't suit some people. Some people just find it too difficult to work from home when they've got the whole family at home and all the children at home, and finding the space to actually be able to do what they need to. They're actually, a lot of people are finding it easier to come into the DHB, come into the bases in the community or the office spaces. And we have office spaces now, because some people are working from home and some aren't. We have the ability in office spaces to do physical distancing. So there's the ability to, you know, sit 2 meters away from your colleagues and all those sorts of things. But it's there's been a combination, really. Some people were, you know, definitely of the mindset that they were going to work from home 4 weeks ago, and then tried it for a few days and find that it actually wasn't as ideal as they thought it was going to be.
Right.
So it's a bit of a mix, really, but we try to enable people to work from wherever they've felt most comfortable.
So have you been working from home?
I am today, but that's not normal. I've mostly been going into the DHB. The main division that I work in is community health. So I would normally travel around sort of 5 different community bases. So I've had to stop doing that and do a lot of Zoom connecting like we are now, and just kind of limit myself to one kind of base.
So the people in the community bases that you refer to, are they OTs still working in those areas but not going out to clients?
So there are OTs working in the bases, and they're going out to clients where there's an essential need. So they are still visiting clients where there's an essential need.
Okay, can I just dig down a little bit further, because I'm sure people will be interested in identifying what is seen as an essential need in that context?
So an essential need for occupational therapy would be anything that was a safety issue, or anything that was going to prevent somebody from being admitted to a hospital. So if, say for instance, we had people in the community who are having manual handling issues, not using equipment correctly, need education on things like hoisting, use of slings, and manual handling in order to maintain their safety at home and prevent them from having any injuries, then those are the kinds of things that OTs are still doing.
They're going physically to the property, to the client, and all right. Okay.
So there's a whole lot of screening that has to happen with every client in the community. So there's a whole lot of screening questions that happen when we're on the phone to a client or a client's family. There's a whole load of screening that happens at the door at a 2-metre distance before you walk into the property, and then there's continued screening as soon as you're in the property and you're kind of looking around and seeing what you're faced with. So as well as kind of, as well as the normal precautions that we take in community, there's a whole lot of other screening going on.
Yes, that's quite interesting that actually is taking place. That sort of personal approach, and still contacting and going to clients' homes, etc.
Yeah, so I mean that, the number of face-to-face visits has dropped significantly. The amount of contacts that we're doing via video conference or via telephone has shot through the roof.
So the community OT in one of those bases that is proposing to go out to see a client, do they check with you or with a senior member to say, look, this is, and is there some triage activity that goes on that says, here's our assessment criteria for when it's necessary to go out and see clients?
Yeah, so there's a triage criteria, there's a priority criteria, there's guidelines, there's screening, and there's also a lot of the time the clients that we're involved with in community would also have other disciplines going in to see them as well. So rather than having half a dozen people rock up at somebody's door, if there's already, say, a complex case nurse involved in that person's care and they are visiting, then how much can we rely on the other disciplines that are going into somebody's bubble to deliver the kinds of things that we need them to?
Well, that's quite interesting. That's the first time I've heard that sort of interdisciplinary sort of chatter about, we're going to see client X. He's a complex case and there's lots of other professions involved. So just talk me through the practicalities of how you bring all those professions together so there's a decision about who's going to go.
The practicalities have been more kind of challenging recently. In the past, it was relatively easy because everybody's in kind of a shared space. So everybody's in a shared space where they're all talking about, who they've seen today and what they've delivered, and this came up as an issue, and that's maybe something that you as the physio want to address next time you pop out to see that person. And so the challenge practically over the last few weeks has been, because we have a more remote workforce, people being restricted to particular bases or people working from home or that kind of thing, that maintaining that communication that we need for that interdisciplinary model of care, that has been a challenge in itself. So we've kind of had to find ways to work around that. And some of the ways that the bases are dealing with it is that they're having what we're calling daily huddles. So Zoom huddles. So it's like a 15-minute, 30-minute check-in every morning. Everybody zooms in from wherever they are. What have we got on today? What are the visits that people are considering to be essential today? Are those essential? Has somebody else already been into the property and, addressed that issue? So we are finding ways around it. It's just more kind of formal, structured ways than perhaps we've been used to in the past, where we've had the ability to all sit around and be in the same space.
Thank you, Jonathan. We hear a lot, just changing the subject a little now, about PPE, personal protective equipment, about the access to it. Have you found there's been issues around accessing appropriate PPE from your perspective?
No, actually. The PPE's always been available in the hospital and in the community, and it's not been an issue for Allied Health to be able to get access, Allied Health and the DHB anyway, to get access to the PPE when they've needed it. There's now really good guidance nationally on PPE and when to use it, when not to use it, what to use. So we're really just through our own kind of internal communications and our own sort of intranet, COVID-19 intranet page with all the information, as one central point for people. We're just directing people to that national guidance.
Right, so that's an intranet for Counties Manukau or the Northern DHBs?
No, it's Counties Manukau kind of intranet, so it's it's where we have all our shared documents and our phone lists and all that kind of thing. We have like a shared COVID-19 page, so if people aren't sure, they're just through that page they're just directed to the national guidelines in terms of PPE use. And kind of like I've said, there's more to it than just the PPE. There is so much screening that happens before we even get face-to-face with the patient. Screening on the phone, screening with our colleagues, screening when we get to the door. So kind of, it's not really been an issue as far as PPE has been concerned.
Working under these sorts of conditions and changes in practice, which to some extent been forced upon the profession, it's called for, I guess, resilience within the profession, and I guess for you too, as a leader of occupational therapy, you have to have some resilience. Do you want to say anything about how the profession has managed in that area?
Yeah, I think there's been a lot of very resilient staff out there who have managed incredibly well over a time of huge uncertainty for sort of how they best deliver what they need to. I think certainly over the past few weeks, I've kind of had an opportunity to sort of through my own supervision and through conversations with colleagues, I've kind of had the opportunity to sort of reflect on a few things as we've sort of gone through the last 4 weeks. And I think there was a lot of anxiety at the beginning of this COVID-19 crisis about what OTs could contribute in a national emergency. And there was a lot of talk about, the focus has really shifted to one that was all about infection and bodily functions and impairment, and kind of felt like we'd really gone back to a real kind of medical model kind of working. And there was a real kind of concern about, that's not a model that occupational therapists feel comfortable working in. So what was it that we were contributing? And one of the sort of reflections I had a few weeks ago was after a conversation with a very smart colleague of mine, who kind of pointed out that what everybody was experiencing in terms of lockdown and what was being reported on the media was a real sense of occupational deprivation. We were all sort of hearing about how people weren't able to do their normal routine and they weren't able to do their normal everyday activities, and how that was having an impact on their health and their sense of well-being. What my colleague kind of pointed out to me in our conversation is this is what our profession, this is the concept that our profession is built on. So we as OTs are in a great position to kind of address those issues that the communities we live in are currently going through. And I guess the other, even more recently, just last week, at the end of last week, the other sort of reflection I had on my drive home was that I've been working a lot with OT colleagues and allied health colleagues, looking at the fact that they're really struggling to carry out the assessments that they want to be able to within the confines of level 4 lockdown and infection control precautions and all those sorts of things. And we're having to think of lots of alternative ways for them to achieve the goals that they need to in delivering their assessments. And again, it was kind of another example of how, as OTs, we can assist each other to find alternative ways to carry out our own occupations and perform our own everyday tasks around the barriers that have been imposed on us by society and by the environment. So I think in terms of that, how can OTs contribute during a national emergency? I think there's a lot that we can contribute, not just to our regular everyday patients or clients, but also to our colleagues and also to the community as a whole, really. So I think what has helped me to kind of get through this period is just having the time to talk to my quite smart colleagues that I have around me, luckily, and do some reflecting and use my supervision and have that time to kind of think, okay, what as OTs are we contributing here, and how can we best do it? And I think there's a lot we've got to contribute potentially.
Yeah, thank you, Jonathan. That's really insightful, I suppose, to reflect on that from your perspective and how you see the profession has adapted and changed to rise to the challenge that COVID-19 and the lockdown level 4 has produced for us. And I get a sense sometimes there may be a lot of frustration from the profession because they're not able to go out there and do what they normally do in helping people to maintain their occupation, whatever that means to people. So thank you for taking the time to have a conversation with me about that, and all the best for you and your colleagues at Counties Manukau.
Thanks very much.
Thank you, everybody. Ka kite anō.